digital prosthodontics, how to prepare teeth, how to make impressions, the laboratory procedures and delivery steps. But like other aspects of our lives, prosthodontics is getting more and more digitalized. And being familiar with digital prosthodontics, especially CAD/CAM technology, is mandatory for an up-to-date dentist. That's why we have planned a short course in digital prosthodontics. Join our outstanding program at Tehran University of Medical Sciences School of Dentistry. Hello, dear colleagues, students, and audiences. Thank you for joining us at this short course program on digital prosthetic dentistry. Unfortunately, we can't have you with us here because of travel restrictions. However, thanks to digital technology, we still can have online academic gatherings like this program. I'm Dr. Farzaneh Farid from Prosthodontic Departments of Tehran University of Medical Sciences School of Dentistry. We planned this course because digital technology in dentistry has reached to such a development that cannot be ignored or neglected. And every dentist should be familiar with this technology and should stay updated. We hope you enjoy our program. For colleagues who are interested in practicing digital systems, we have on-site clinical course too, and we will be happy to see you here. So let's go on and begin our course. In the name of God. We are talking about digital prosthetic dentistry because in recent years we have seen a lot of developments in digital technology that have found many uses in dentistry, like CBCTs, like CAD/CAMs, and so on. So it is necessary for us to be familiar with this kind of the technology. However, I want to tell you that prosthetic dentistry is not about the technology. It is about what we do for our patients. And our ultimate goal is to restore the oral health of the patient and provide the patient with a prosthesis that is durable, functional, and aesthetically acceptable. However, you may do it with a conventional technology or with digital technology. It is not the kind of technology that is important. The most important point is the goals that we have to achieve. The most important point is we should give our patients the best that we can give them. At the right side, you see an endocrine that was done by our graduated resident, Dr. TUMS. This kind of actually, this kind of treatment can be done by digital technology or by conventional technology like heat press technology. So the most important point for us is how to restore to the best, not the kind of technology that we are using. The digital technology can help us in many ways. One of them is in the laboratory procedures. It makes the laboratory procedures faster and with less steps. And the results, as I saw, is have less complications. However, the CAD/CAM or digital laboratory procedures are not the only use of digital technology. We can have this kind of technology in education. We can use them in education. In the past, when I was a student, we used to read books, textbooks. And in dentistry, the illustrated textbooks were very useful, especially colored illustrations. They were gifts. Nowadays, students have PDF of these books, and in the PDFs, the illustrations can be sharper and they can enlarge it, so it helps them a lot. 3D softwares are not available for, especially for basic sciences. So what you could see in the textbooks two-dimensionally, you can see three-dimensionally with softwares. So it is another help that digital technology can do for us with especially for dental students and for continuing educations. In recent years, we have interactive dental education softwares. These softwares are they not only are books, illustrated books with color illustrations, also they have animations inside them. No links. They have animations inside them. So this is also very helpful for the students. I don't know. I don't have the actually the feedback of the students how much this kind of books can be helpful for them, but it seems can be amazing. In recent years, also we have dental patient education softwares. It helps our patients to know what to do before and after treatment. Now let's go one step forward for preclinical trainings. As you know, we used to have dentics or dental forms, and later we had actually phantom heads. With the phantom heads, students begin to practice dental preparations before they go to the patient and work on the patient's mouth, in the patient's mouth. And they were very useful. These simulations were very useful. Nowadays, we have dental quantum heads that are connected to monitors, and whatever the students is doing can be seen inside the monitors. So she or he can see what if is doing right or wrong, and can fix it at the real time. And the computer, the software or the program can say that the student that you are going wrong, and even it can grade the student's work. The next step is virtual reality. In this kind of program, actually, or this kind of training, you use virtual dentics or dental forms. It is not real, but you can interact with it. It means that when you are preparing, you prepare a tooth without to be any tooth there. It is not real, it is virtual. And also you can feel passing through enamel, reaching denting, or entering the pulp chamber. It is called haptic sense. It is a touch sense, very sensitive touch sense. The advantage of this technology is that you don't need any more real dentics, or at the end you can use real dentics. It is repeatable. However, the technology is very expensive at the time. We hope the pioneers use it and then give us the feedback of how much it can be helpful for the students. This is the foremost, it seems the foremost progress. It is a robotic patient. It has all the um, features that a real patient has, like salivations and tongue tracing and so on. We also have augmented reality. It means that we add some virtual features to a real feature. As you see here for the injection, and you inject in reality, but in the monitor you can see also where your needle is going. It can be very helpful for learning different part of dentistry. Also, there are softwares that can help to show the patient what will they have after treatment, after full mouth treatment or full mouth reconstruction, like this one. Now we are reaching to clinical practice. As you see, the iconic feature of digital technology in prosthodontic field is CAD/CAM technology. Here, as all of you know, we should have a digital model or a virtual model of the patient's mouth. In conventional way, we took impressions and broadcasts and cast to represent the model of the patient's mouth. In digital dentistry, we should digitize the data from patient's mouth, either by directly scanning teeth inside the mouth, or indirectly scanning the cast of the patient, or even the impression materials. And then, like any other prosthodontic treatment, we should have jaw relation records. It can be, we can have recording jaw relations directly inside the mouth, like the left figure, or we can, in more complex cases, we can scan the cast mounted on the articulator. So we also have virtual articulators, not only real articulators, but also virtual articulators. How to transfer the data from the cast to the virtual articulator in the software is different from software to software, but it is now available. After that, we have designing and manufacturing, and it is something that my colleagues will talk for you in details, so I don't stop here more. Another step forward is motion tracking. It means that you can see how the condyle is moving inside the glenoid fossa when the patient opens and closes, and it seems very interesting, especially for the TMJ disorders. Also, you can trace and register the jaw movements as you do in pantographs, but here you do it with virtual, with digital technology. Now let's go to clinical cases and what we do in the clinics. I want to say again to emphasize that we can do many of these procedures both conventionally and digitally. But sometimes the digital technology helps us more, and sometimes it is not possible to do it with a technology other than digital, because some materials like zirconia or PIC are just used with digital technology, not with anything else. So it is on you to decide which kind of technology you are going to use. This is my case in my implant fellowship course. This patient has 6 implants at upper jaw and 6 implants at lower jaw. She wanted a fixed prosthesis, and the crown height space was about 12 millimeters or a bit more, and we should have something that we call it a Fitchery treatment. So we decided to give the patient metal substructure with multiple metal ceramic crowns on it. And actually, substructure was for compensating for the bone loss that she has. Before it, we gave the patient a prosthesis, temporary prosthesis made from pig. This prosthesis is completely made just with digital technology. As you see, the connection area and the prosthesis are in one piece, and you can do it with something other than digital technology. You just can't do it with milling. We gave it to the patient and to know if she is happy with the form, with the contour, and with the occlusion. With minor modification, we made, or actually lab made, this metal substructure. You see this both substructure from upper jaw and in the lower jaw are in one piece. They are not segmented, and they have no holes other than the access hole to the implant. Doing this with conventional technology is very difficult. I will see you with a slide later. This is the metal ceramic crowns on the metal substructure. The part of the metal that can be seen will be covered with the pink porcelain. This is the patient after 4 years, and this is the radiography of the patient. Perhaps you remember that the implants were not completely parallel to each other, but I found that with this technology, the framework seated very passively and in very good, which we had no problem with the sitting of the metal substructure. This is another case. I just want you to show that how we cover the metal substructure with pink porcelain. Here, as you see, we are comparing the conventional technology with the CAD/CAM technology. At the upper part picture, you see the CAD/CAM technology. Everything is in one piece. Every margins are sharp, and for the lab, it was very easier to make it than to wax up, like the lower part, like here, to wax up it, and to have a screw attached to the correct places. Because if you have any problem with a screw attachment, with a wax up, or anything like that, you may not have a complete casting, and it would be very difficult to redo the castings. Here, as you see, it's very nice work, but with a conventional work. And here you see that we have segmented castings and holes, because it would be very heavy. And so Dr. Atri and Um, so again, as you see in the upper slide, we had a, a one-piece metal substructure. It is not segmented. It doesn't have any holes other than the holes to the implant. But if you want to do it with a conventional technology, as you see, you should have a very sophisticated wax saw. The position of screw attachments are very important because you may not have a complete casting if you don't care about the position of the um, screws. So it is very laborious work for the laboratory technician. Um, and you see here on the right side that the substructure should be sectioned because it is very difficult to have the substructure in one piece when it is going to be cast. Um, that's why the milling is better for this kind of treatments. This is another patient. It has a problem with the nose area, and here what you see as nose is skin graft. He had a lot of surgeries, more than 30 surgeries. The last one was they got bone from one of his toes, and they had put implants inside it. And then he came to us for putting the prosthesis on the implants. For the lower part of the jaw, it was very easy to put the prosthesis. For the upper jaw, it was very difficult, very difficult. Each time, even taking impression was very difficult to have um, putting impression cuppings, tightening abutments. Everything was very difficult. Every time it takes more than 3 hours for me to reach to this point. And when we reach here, I found that at the back we don't have enough space, and then we had a implant failure. One of the implants failed. So we decided to, and also this is too long. It was interfering with the tongue, and it was clear that if we want to give him a process on this resin pattern, it would be very annoying for the patient. We decided to give him for temporarily a prosthesis that was made from pig. At that moment, I considered that what was the problem. As you see, the direction of the connection that goes inside the implant to the direction of the crowns is 90 degrees. They are perpendicular to each other. I had never seen, and I have not seen yet anything like this anymore. And when I asked my colleagues, they said that they have not seen something like this too. And we just can't have this kind of treatment for this patient. It means that we can't have any conventional treatment for the patient because the direction of the abutment would be not in the direction of the completely different with the direction of the crowns. So here again, digital technology helped us to give the patient something to have inside his mouth. I don't know, have you ever been made to take impressions of the patient under general anesthesia? This patient was not cooperative at all. So they put implants under the general anesthesia, and I made the impressions at the final impressions at that time. Now I'm thinking perhaps it was better if we had the intraoral scanners, and we could have scan bodies attached to the implants and taking impressions with intraoral scanners. However, I'm not sure if it would be better or not. Here is a maxillofacial prosthesis. In the past, if you want to give the patient such a prosthesis, you have to make the impression during the surgery. But nowadays, you can have CBCT or CT DICOM files and actually design the prosthesis, and you can have a 3D printing the prosthesis and the skull. It is much easier than before, and then at the surgery you can give it to the patient. Another help of digital technology is model surgery. In the past, we used to do model surgery on the casts, but here you can use the digital technology to do the model surgery. Do you know where you can cut the bone in relation to the nerves and to the root of the teeth? So, and how to change the position of segmented area, and then in the last occlusion. So it seems very helpful to, also to the prosthetic dentistry in the final stages. What I'm going to, I want to tell you is that sometimes the best results can be gained by conventional technology, like when you are veneering a crown. Sometimes it is better to use digital technology, and sometimes there is no other option than digital technology. So it's up to you to decide about it. And thank you so much for listening to my lecture. I hope you have enjoyed it and it has been informative for you. Thank you a lot. Now we will have our next lecturer, Dr. Azamfari. And Dr. Azamfari is one of our colleagues in dental dental university, Tehran University of Medical Sciences. I hope you enjoy it too. So, Dr. Azamfari, please go on.
Good morning, everyone. On behalf of Tehran University of Medical Sciences School of Dentistry, allow me to extend a warm welcome to you. Let me briefly introduce myself. My name is Rezvana Ghazanfari, Assistant Professor, Prosthodontics Department, and the purpose of this presentation is the comparison of conventional fixed prosthodontics and digital fixed prosthodontics. By the focus on digital fixed prosthodontics, I will have some definition about digital impression and digital manufacturing. Now, let me start with conventional fixed prosthodontics. In a simple case of a single crown, the first clinical step is tooth preparation, then an impression will be made, then working cast and die will be fabricated. Wax up for the restoration will be done, casting and investing will be done, metal framework trying and porcelain trying will be done, and in the last clinical step, delivery and cementation will be done. In this chart, briefly, you can see the conventional workflow for fixed prosthodontics. In this picture, red color is used to emphasize on this workflow. Clinical steps are tooth preparation, conventional impression, conventional gypsum dyes, conventional wax pattern, conventional casting and pressing technique, and the product final restoration. Now let's talk about digital fixed prosthodontics. It's obvious that for dentists already skilled in conventional workflow and analog techniques, the move to digital technology comes at a cost in equipment and software. On the other hand, the increased efficiency gained in dental treatment can offset the costs. For dental laboratories, digital technology allows increased standardization and wide variety of materials and techniques can be chosen and used. In this chart, in yellow color, now you can see an entirely digital workflow in prosthodontics: tooth preparation, digital impression, digital dyes, CAD pattern, CAM milling technique, and the product final restoration. In this picture, you can see digital impression and designing of the final restoration and a digital dye. And in this picture, you can see a printed cast with a final restoration. So it's obvious that intraoral scans are made into physical casts like the picture on the upper part of the slide, or intraoral scans are left as digital casts, as you can see on the lower part of this slide. So the products of digital technologies and digital impressions may be different. Okay, up to here and up to now, I talked about conventional workflow, which is defined on the upper line of the chapter, the chart, and digital workflow, which is defined in the lower line of the chart. But some combinations of digital and conventional workflow may be used. For example, suppose that you prepare a tooth, you make a digital impression. From this digital impression, printed resin dyes will be fabricated, and then you can make resin pattern or wax pattern on it, and then in a conventional way, you can use it for casting and pressing conventional technique, and finally, the restoration will be produced in a conventional way. In another example, you can prepare tooth, you can make digital impression, digital dyes will be produced, and then printed pattern will be produced from this digital workflow. And the outcome is printed pattern. Then the laboratory can use this printed pattern to use in conventional casting pressing technique, and finally the restoration will be fabricated. In this slide, on the right side, you can see a milled wax pattern, a full contour one, and a milled wax pattern, which is a coping. On the left side here, you can see printed resin dye for fixed prosthodontics. So we can use different products of digital workflow to simplify conventional workflow. These pictures talk about different products. On the right side, you can see CAD/CAM full contour zirconia crown, and on the left side, you can see CAD/CAM pattern, and this will be used in conventional casting technique. As I told you, one of the most important steps in digital workflow is digital impression. Now, let's talk about digital impression. The significant question is why utilize digital impressions? Digital impressions are easier, better, and more efficient techniques. By using this technique, patient satisfaction will be increased. There will be the possibility to evaluate your preparation in real time. And it's obvious that the possibility of dimensional changes, the shrinkage, will be reduced. And milled cast or 3D printed cast may be fabricated. Digital acquisition units categorized into two main groups: sole impression system and CAD/CAM impression systems. Sole impression systems do not have the ability to design or mill the restoration chair side. The examples of sole impression systems are Ultra system, through definition scanner, trio scanner, and on the other hand, CAD/CAM impression systems allow for one day or one appointment dentistry. The example of CAD/CAM impression systems are PlanScan, Serif 3D BlueCam and OmniCam, and Carestream CS. In this picture, you can see 3M through definition intraoral scanning system and its wand. And this is OmniCam intraoral scanning system and its wand. This is PlanScan intraoral scanning system. This is Carestream CS. And in this slide, you can see captured screenshots of a partial arch digital impression, which is made by different brands of oral scanners. Now, let's make a rapid review on digital impression technique. It's very important to know that the basic principles for making an accurate digital impression is the same as for conventional impressions. And if you cannot visualize the structure to be captured, you cannot capture the actual structure. Dryness is very essential and critical. Hemostasis is essential in all systems, and these rules are the same for conventional impressions. The same as conventional impressions, visualization of finish lines or margins is critical, and using retraction cord in order to retract gingival tissue is essential. It's obvious that we do not capture the impression of just the prepared tooth. Minimum of one tooth on either side is essential. Opposing arch and buccal bite should be also captured and impressed. This technique has got some contraindications. The major contraindication is inability to access the area. And another contraindication is lack of patient cooperation. So stillness is essential. After making the digital impression, file format in digital workflow will be noticed. Actually, the most common digital file format is STL, which stands for Surface Tessellation Format. And now let's talk about digital manufacturing. Devices used in digital manufacturing fall into two main categories: subtractive manufacturing technology, SMT, and additive manufacturing technology, or AMT. On the right side of this slide, an example of subtracting manufacturing technology, or SMT, is shown. And on the left side of this slide, an example of additive manufacturing technology is shown. It's very important to know that subtracting manufacturing technology is generally limited by geometric complexity. And it's very important to know that additive manufacturing technology can be used in fabrication of more complex organic forms. But in dentistry, the predominant technology is SMT. Subtractive manufacturing technology may be done in two ways: hard milling and soft milling. Hard milling is used for materials that actually can be milled in their final state. Example of these materials: composite ceramics, or some ceramics. This is the picture of a hard milling material. And about soft milling, in soft millings, materials actually cannot be cut in their final state or final phase, so they are milled prior to final state. This is the example of soft milling. It's very important to notice that both subtractive manufacturing technology and additive manufacturing technologies can be used in final restoration fabrication and also provisional restoration fabrication. This is the example of milled provisional restorations. And on the other hand, additive techniques may be used in this clinical visit. Actually, this is the last slide that brings me to the end of this presentation. In this presentation, in summary, I talked about the comparison of conventional and digital fixed prosthodontics. I make an introduction on digital impression and digital manufacturing, and also the combinations of conventional and digital workflow were discussed. Thank you all for listening to this presentation. I'm so happy to be here, and it's a pleasure of mine to be in this symposium. If you have any question, don't hesitate to ask. Thank you.
We are all familiar with conventional prosthodontics, how to prepare teeth, how to make impressions, the laboratory procedures, and delivery steps. But like other aspects of our lives, prosthodontics is getting more and more digitalized. And being familiar with digital prosthodontics, especially CAD/CAM technology, is mandatory for an up-to-date dentist. That's why we have planned a short course in digital prosthodontics. Join our outstanding program at Tehran University of Medical Sciences School of Dentistry.
All right, good morning, everybody. I hope so far we had so much information. We had two lecturers, and I would like to introduce the next lecturer, Dr. Mustafavi. She's going to present for us by a couple of minutes. This topic, the digital dentistry, it's a very hot topic recently, and we are dealing with this technology and virtual stuff. So we have to be ready for dealing with this technology. So is she ready? Is she coming, or is she online or not yet? I don't know how many people are online right now, but if there's any questions regarding the recent presentation. Dr. Mustafavi, she's assistant professor from Tehran University. She has been here for more than 15 years, and she's right now working with the undergraduate students and postgraduate students here in Tehran Dental University. Is she here or not?
همینجا با چپ بزنم.
I do have a question coming up here regarding the scanning and make the impression in a virtual way. Yes, we can do the impression by oral scanner, and there is no need for a lab technician. The thing is, when you make the impression and you with the CAD cam you make the crown, probably for proximal contacts, you may need a cast later on. So if the proximal contact is not perfectly fit, so probably at that point, you need to make a pickup impression. At that point, you may need a lab technician. Otherwise, you can make the virtual impression with the oral scanner and then design the crown and print it out or mill it out. So that's the way you go with the scanning and CAD/CAM technology. All right. Is there any other question, or we can go on with next lecturer?
Sorry, Dr. Satterford, do you have my voice? Can we start? Hello, everyone. My dear colleagues, good morning. My name is Dr. Mustafa, and I hope you to be safe and healthy during this pandemic. It's a great pleasure to make connections to this virtual platform, which was not possible to hold in person at this time. The title that I'm going to speak about here is the preparation principles for CAD/CAM restorations. Do you think that they are different from the conventional ones? So let's see. When a patient like this case comes to us to rehabilitate the teeth, we need to consider the final results, of course, through the diagnostic workshop. So we will be able to prepare the teeth in a way to receive the restoration, which will establish the aesthetic, phonetic, formal function of these destroyed teeth. Okay. And the key to a good restoration is a good preparation, of course. I know that all of us are familiar with these two preparations thanks to Dr. Schlimberg and the factors affecting these principles. Maybe you have seen the preparation considerations categorized in biology, which affect the appearance of the palate, which affect the health of the oral tissue, aesthetic, which affect the appearance of the patient, and mechanical, which affect the integrity and durability of the restorations. Do you think that these considerations would be changed if we apply the digital workflow? Optical scanning demonstrates accuracy that is similar to traditional ones, even better. In particular, the dentist receives immediate feedback about their work, and it prevents the additional appointments. In fact, tooth preparation principles are almost the same on both conventional and CAD/CAM cones. However, the CAD/CAM cone preparation design must accommodate some considerations, like milling and scanning. According to the literature, general dental practitioners seem to have difficulties to fulfill the principles to tooth preparations for CAD/CAM restorations. The Primary reason for the failure of ceramic restoration is inadequate reduction. Proper reduction provides adequate thickness of the porcelain to withstand occlusal forces and avoid fracture of the restoration during the milling process. Do you think that this restoration failure can be avoided by modified preparation? The answer is yes. It has been shown that the preparation design can reduce the physical stress and consequently increase the strength of the restoration by semi-spherical cavity floor segments, rounded cavity shapes, and prevents classical valves and step rotation. As you can see, two factors play a key role in preparation design. Each specific material needs a certain thickness to be resistant against forces. On the other hand, diagnostic backstop, which is of course verified in the patient's mouth, tells us about the available space. When we apply digital workflow, we encounter some limitations. There exists some difficulty in recording the margins which are not distinct enough. For example, feather edge finish line, and also sharp angles. Furthermore, there exist some limitations about the milling instruments. So before talking about the guidelines, let's become familiar with them. Look at this image. Nearly all dental restorations has an outer and inner surface, but as you see, our preparation has direct effect on the inner surface of the restoration. Here, you can see the milling burrs. For example, CEREC milling machine apply these burrs for formation of the restoration. It can be different in other milling machines, but the philosophy behind it is the same. The stepper, as you can see in the top of the picture, is responsible for milling the intaglio, I mean the fitting surface of the restoration, and the other burr mills only the occlusal surface. According to the length of the stepper, which is 10.5 millimeter, the height of the abutment should not be greater than this amount, which is rare in our daily practice. The stepper is able to mill 0 degree surface, which is less than 4 millimeter, as you can see in the picture. Surfaces greater than 4 millimeter in length should have a 3 degree taper or greater. This is due to the existing steps on the burr. If we draw a line from the bottom of the burr to the top of it, this angle would be 3 degrees. As you know, most of the restorations would be prepared with the first 4 millimeter part of the burr, but sometimes the abutment height would be greater. Although the system gives you an option if 3 degrees of the taper cannot be achieved, and it is the step burr mode. We spoke about the length, but what about the diameter? In preparation of molar teeth, the diameter of the burr does not have a great effect, but when we approach to the anterior segment, especially the inferior mandible and incisors, the diameter becomes more important because the anterior teeth, as you know, are smaller than the posterior ones. Considering the burr diameter, the width of the preparation in the incisal part should not be less than 1 millimeter. Remember that it is of great importance. But this concern somehow faded in zirconia restoration. What do you think about it? We will answer it in the following slides. To predict the thickness of the anterior teeth before preparation, we can measure the facial-lingual thickness of the teeth at the junction of the middle and ancizal 1/3. If the thickness is less than 3.5 millimeter, the ancizal edge of the preparation may be too thin to accommodate to the milling burr. Of course, it depends on the milling burr diameter. So we should try to keep the ancizal edge of the preparation as flat and as wide as possible without compromising the vertical height of the abutment. Now I want to talk about the drill compensation. Drill compensation is a process in which the internal surface of the restoration is designed for compatibility with the burrs in the milling unit. The amount of drill compensation, as you see, is determined by tool shape, material substrate, and tool diameter. According to this image, you can see the ideal internal shape in the middle of the picture. But when the burr diameter does not match the preparation shape, the CAD software enlarges that internal surface to accommodate the diameter and shape of the milling tool. After drill compensation, the internal surface would be as in the right picture. In this regard, final material thickness becomes more thinner due to the over-milling. We have excess cement space, but complete seating of the restoration. So, flattening the sharp cut teeth and anatomic reduction can prevent over-milling and compromising material thickness. Also, stress accumulation would be happened in this area, which will be susceptible to fracture. Likewise, in case of utilizing grooves and boxes in the preparation, corners should be avoided. This question again. It says why the effect of drill compensation and zirconia restoration are barely visited. As you know, zirconia blocks are in partially sintered phase, and milling and enlarged restoration about 25 to 30% bulkier is an advantage to zirconia, and after that it would be shrinked. So you can see drill compensation which result in material bulk fracture through overmilling. Since milling units present different sizes of milling tools, you may ask that why we don't choose a smaller diameter. Okay. Although choosing a small milling tool diameter will provide more intricate preparation features and the overmilling would be minimized, the milling time would be increased and the milling burr loses its cutting efficacy and it requires more frequent replacements. So let's speak about the principles. According to the previous consideration, it is recommended 1.5 to 2 millimeters for occlusal reduction of ceramic restoration. This reduction provides adequate thickness for ceramic to withstand occlusal forces and avoid fracture of the restoration during milling process. The amount of reduction depends on the selected material. For example, in case of monolithic zirconia, less than 1 millimeter is recommended. Of course, the thickness should be enough to form the occlusal morphology. Otherwise, the definitive restoration would be flat without natural rooting. We can verify adequate reduction through different ways. For example, dismacing the burrs ensure that there is adequate space, or other ways. You can use them. For example, silicone decks, these flexi tabs. or even these plastic instruments with different thicknesses. According to this survey, increasing intercostal angulation of their other preparation results in decreased retention force because of the surface, of course, without affecting the resistance form significantly. Marginal integrity of all specimens was in the range of acceptable dimension. Okay, you know about the minimum abutment height, which is required. It is 3 millimeters for anteriors and premolars and 4 millimeters for molars. But the important point is that this value should be considered with the total occlusal convergence and width of the preparation. The greater the buckling wall dimension of the preparation, the lower its resistance form against lateral forces. The amount of 0.4 ensures proper resistance in our daily practice. Studies have shown that convergence angle of 6 to 10 degrees allow trying of the ceramic restoration without the risk of the fracture. Good result for scanning, also complete visualization, complete stitching, and also avoiding undercuts. Also, it is necessary to achieve a depth of 1 to 1.5 millimeter reduction in axial walls. Okay, realistic clinical total occlusal convergence compared to ideal one can apply both for conventional restorations and CAD/CAM restoration. Studies assessing preparation total occlusal convergence in daily practice reported mean value between 18 to 23 degrees. This survey shows that intraoral scanner is more accurate rather than polyvinyl silent scan or stone scan in recording the total occlusal convergence, especially when we approach to 0 degree. All of the line angles should be rounded on the preparation for all ceramic restoration to reduce the stress in the prosthetic material. It also facilitates the laboratory process and fitting of the prosthesis. Okay, chamfer shoulder withdrawn internal angles about 0.8 to 1 millimeter depth is recommended for ceramic restorations. 0.8 millimeter depth is considered, especially in proximal parts of premolar teeth and the lingual side of the molar teeth, and 1 millimeter for the other side. We can use these self-limiting layers to prevent gutter margin. Furthermore, a spike margin cannot be replicated by rotary instruments, and the risk of open margin would be increased. Margins should be sharp enough in order to record by the scanners. Also, beveled and feathered margins are contraindicated because of increased risk of fracture. Supragingival margins, as you know, are considered to be preconditions for adhesive cementation and periodontal considerations. And also, supragingival margins simplifies the process. Margins should be smooth and continuous. Thin margin, as you can see in this picture, may lead to the material fracture during milling, followed by an open margin in the restoration. In case of sharp angles, which don't accommodate milling tool diameter, over-milling would result in open margin. So it is important that all of the transitional angles, edges, and corners should be rounded. Or you can correct them in the CAD space. Okay. You need fine preparation after coarse preparation. You can use a fine diamond that is the exact shape and size of a reduction diamond, which will ensure the smooth surface. For shoulder, you can use these bare with blue color coded. It will finish your finish line without preparing the axial walls. As you know, the difference is in the grid size. Oh, about the undercuts. In a conventional impression, block out the undercut prevent distortion of the impression when it's removed from the patient mouth. However, undercuts are not a restricting factor in digital impression. In addition, minor undercuts can be easily managed in the CAD phase, for example, by changing the path of insertion or digitally blocking out. Before fabrication, the restoration, of course. But as you can see in the picture, if the undercut is in the vicinity, it is very close to the external surface of your preparation, it would result in open margins. You can use your software mill preview or I think the undercut check in the milling machine to prevent these features or to correct them. Okay, you can be aware of about occlusal contact. Before starting the preparation, you can check them with the articulating paper, and the edge of the restoration should not be placed in the occlusal contact. It will result in deterioration of the marginal integrity, of course. Okay, this is a screenshot of the points you should consider in preparation of the posterior teeth. Of course, each intraoral scanner and CAD/CAM system may have a specific recommendation for the preparation in that system according to the special material they recommend. So the internal angle should be rounded. You should be aware of about adequate reduction, and the margin should be sharp and visible. And these are the points that we covered it already. This is a snapshot is about the preparation of the anterior restorations. About the reduction, about the margins, and also install edge should be as flat and wide as possible. Manufacturers propose guidelines of tooth preparation according to the specific what they recommended and its mechanical properties. So we should inform about it. For example, you see the guidelines for two materials in the same company, but the reductions are different. Okay, you can see the hints for on restorations. You should consider rounded internal line angles against 6 to 10 taper of the internal axial bores, and the occlusal reduction should be more than 1.5 millimeter. Margins should be sharp enough in order to be recorded by scanners, and in the interproximal area, the flare should be about 100 degrees in order to prevent undercut and accurate bioceramic. About the inlay restoration, the margin should be sharp again. You should be careful about the reduction and round internal line angles. Also, the dimension of isthmus is very important, in which the width is recommended to be 1.5 to 2 millimeter and the depth 1.5 millimeter. And about the veneer, the reduction should be uniform and smooth depth cuts are considered according to the discolorations of the tooth. And interproximal chamfer margin are properly prepared, and they should be distinct enough. Okay, let's speak about armamentarium. After practicing for a while, all of us prefer to develop a group of bears for our own practice. Specific bears also have been designed to facilitate preparation of tooth surface for all ceramic restoration, and several companies have different kits for them. As you can see, London bear is very practical. Also, we need some bears which makes transitions without sharp angles, like this. To sum up, you can remind these tips. You should have a smooth tapered wall, sharp, well-defined margins, rounded internal angles, exit angles and margins about 90 to 120 degrees, and adequate tooth reduction according to the selected material, and of course the diagnostic backstop, which has been verified in the mouth of the patient. Sorry. In conclusion, I can summarize the whole process as you can see. First, evaluate the patient's condition. Select the material. Communicate with your lab. Perform the preparation according to guidelines with appropriate armamentarium, and then do a proper scanning. And after all, and finally, be sure to check the design. At the end, I like to finish my lecture with a poem of Omar Khayyam. He said, این یک دو سه روز نوبت عمر گذشت، چون آب به جویبار و چون باد به دشت. هرگز غم دو روز مرا یاد نگشت، روزی که نیامد است و روزی که گذشت. Thanks for attention, and I would be happy to answer your questions that you have. And also, this is my contact information here for asking questions and share ideas.
All right. Thank you so much, Dr. Mosafavi, for a wonderful lecture. If the audience have any question, please write it forward, and
speak a bit louder, please.
The questions. Meanwhile, I would like to introduce the next lecturer, Dr. Faiza Atri. She graduated from Shahid Beheshti Dental School in 2011. Then she went to postgraduate advanced prosthodontics in Tehran University, and he received her master in prosthodontics in 2014. Since that time, she's the clinical director of undergraduate students, and she's ready to go for the next lecture.
Thank you, Dr. Mostafavi. It was very great. It was very informative. Thank you so much. Okay. Thank you so much.
Have a nice day.
I think it was very good to know how to prepare a tooth for CAD/CAM restoration, because it's a bit different from the conventional restorations.
Right. Whenever we have a preparation topic, we see a lot of audience and they're interested in preparation. And although we teach it from the beginning of the fixed prosthodontics, but most of the dentists, when we deal with the real dentistry, they know how difficult it is, and they know their, the weak point. So they're willing to have this lecture. So, and as you said, regarding the recent restorations, it's a transition time from shoulder bevel that we, we taught from the PFM restoration to chamfer and modified shoulder. So we all need to be upgraded and be familiar with the new type of preparation for CAD/CAM restorations. All right, I see Dr. Atri is online, so move on, please.
Dr. Atri, the stage is yours. Please go on. Please go on, Dr. Atri. Start your presentation, please.
We're ready to listen your presentation. Carry on, please.
Okay, do you hear me? Okay, hello everyone. Welcome to this presentation. Let me start myself in few words. I am Dr. Atri, Assistant Professor of Tehran University of Medical Sciences. I am here to talk about digital wax-up and mock-up in this session. In every aesthetic treatment, we have some purposes. First of all, we want to establish new smiles with minimally invasive approaches. And second one is to have a restoration with maximum natural effect. Means we want to have a natural looking restorations, not an artificial ones. Also, we should restore the mastication and phonetics, and all in all, we want to provide better quality of life for our patients. Today's aesthetic treatments are totally different from what was in the past because our patients' demands are ever increasing. And when they come to our office, they have high level of information. They searched a lot, they Googled, they saw some pages in Instagram, and so we need to have a customized treatment for them, not a standard one for everyone that seek for aesthetic treatments. And we should consider individual psychological characteristics of our patients. If ignored these points, it leads to aesthetically dissatisfaction of our patient, and to satisfy them again is really a difficult task. So in each aesthetic procedure, we should have wax-up, diagnostic wax-up. Actually, it is a tool to evaluate the treatment plan for dentists and technicians. And we can show the result to patients. And it's important to correctly diagnose this proportion before any irreversible restorative dental procedure. Means that we can get a vision about our planning, if aesthetic crown lengthening is needed or orthodontic treatment is needed before aesthetic smile design, we should consider in this step. In this slide, you can see 4 cases, which all of them came to office with one same complaint. All of them seek for a more beautiful and nice smile. But let's evaluate the scenarios. In first scenario here, you can see spaces between teeth, and from the dentition, we found that it is the patient is a young patient, and he or she have a deep bite, and we should know that the left side is okay and right side is just a space. The second case is a patient with broken teeth, and from the dentition, we found that it's a child. We have some permanent teeth that are semi-erupted and some deciduous teeth. And so we should treat these broken teeth. And the third case is a person who have some caries and discolored filling, and also a previous crown. And we see lack of papilla here. And we should consider different treatment for him or her. And in the last case, you can see a patient which dentition said us that the patient is middle-aged with generalized gingival recession. And as you see, all of them came with same complaints, but treatment planning is totally different for each of them. First of all, we should start with impression making. We can have conventional impression making. As you can see here, the best material is additional silicone. We can use light body injection in the mouth, directly in the teeth, and putty in tray, and we can get an accurate impression. Also, we can do it digital with intraoral scanner, and we can scan the upper and lower jaws and occlusion together. So we should start for treatment. But as you know, we have some ideas, our patients have some ideas, and also our technicians. And where to meet different ideas together and to achieve to a consensus to start plan. You should know that the start of smile designing is dental photography. Dental photography is really a valuable tool for communication between dentist, patient, and technician. As Dr. Kochman said, we need 6 pre-op records of photo. You can see here. The first one is facial frontal retracted with teeth apart. And the second one is facial frontal smile with teeth apart. The third and fourth one is facial profile at rest and smile. We need to have an occlusal view of the upper jaw without mirror, or we can get it from the model. And the last one is a 12 o'clock view smile. Means we ask patient to put the head downward and get a photo from the above. In this photo, we can evaluate the projection of the teeth. And we need 4 videos. The first one is face casual interview. Means in a social distance, we ask patient to speak and we get video. The second one is close-up. Means in a closer view, we get a video from speaking of patient. We can ask them to count, smile, and say something to evaluate the relation of teeth to soft tissue and the teeth show. The third one is intraoral functional movement. Means we ask patient to put teeth in occlusion and then to move the lower jaw in protrusive and right lateral and left lateral side to evaluate the functional movement of the jaw. And the last one is the structural occlusal view of upper jaw. So we should start from principles. In aesthetic smile designing, we have 2 reference lines from the face. The first one is horizontal reference line. The line that is passed from the papilla eye and its name interpapillary line, which should be parallel with upper lip line and the incisal edge of the anterior teeth. Means the occlusal plane should be parallel with this reference line. The second reference line is vertical line, which is perpendicular to the horizontal reference line and is in the midline of the face. And it is present to be coincident with the midline of the teeth. We should evaluate the smile in closer view. The visibility of teeth is one of important factors that we should analyze. More the teeth be visible, the smile is younger. And as you know, with increasing the age, the soft tissue have more tonicity and cover the teeth, and we have less teeth show in middle-aged people. The second one that we should analyze is a smile curve. A smile curve is the curve of lower lip in smiling, which should be parallel with incisal edge of the anterior teeth. And it should be pleasant to have this parallelism. And the third one is buccal corridor. The corridor and space that we have in the buccal surface of posterior teeth to corner of the lip. If we have a large buccal corridor, it would be not pleasant, and we have a dark triangle here. And if we have a really small and narrow buccal corridor, it looks like artificial. It's something like we have in denture, and it should be normal, as you can see here. In more exact evaluation, we should check the teeth closer. It's better to have midline of upper jaw and lower jaw coincide and be on, and also the teeth axis be parallel and a little convergent to the midline. We should evaluate the gingival zenith, as you can see here, and connectors. And one of the most important parts of the teeth are incisal embrasure. As you can see here, in the midline, the embrasure is small, and when we go posterior to the posterior teeth, we can see the embrasure is more large. For example, the embrasure between lateral teeth and canine is larger than embrasure between two centrals. Also, we should imagine the age and sex of patient in a smile design. As you know, with increasing the age, teeth become more worn, and so we have a smaller embrasures. And in young patients, we have large embrasures and sharp line angles. Also, the sex is important in a smile design. For example, in men, we have a more bold mold, and we have sharp line angles, and in reverse in females and the women, we have round line angles and more soft model of teeth. One important factor in smile designing is to have harmony without exactly symmetry. As you can see here, this smile is really pleasant, is really nice. But when you zoom in, none of these teeth are exactly the same and symmetrical. And you can see that the type of embrasure, the line angle, have some differences between two sides of the mouth. And it is natural and pleasant. Actually, in nature, we have not exact symmetry in things. And in wax-off and modeling, we should consider that we have harmony without exact symmetry, because exact symmetry can make an artificial view for teeth, and it's not favorable for us. Okay, in digital smile design or DSD, we do a smile designing in software. Actually, it has some advantages. The first one is participation of the patient on this designing procedure, and it leads to a customization of a smile design for each person according to her or his needs and desire, and it's in complement with morpho-psychological characteristic of the patient. And we can check the emotional level of our patient, and it increases their confidence in the process. And it results in better acceptance of the anticipated treatment. As you know, the treatment should be customized according to the morphopsychological features of our patient. For example, if our patient is a fashion model or hairdresser, we have a special smile designing. Or if our patient is a boss of a company or assistant professor in a university, we have some other consideration for it. You can see different VST softwares here. Some of them are really accessible for everyone, like Photoshop, Microsoft PowerPoint, and the others are professional, as you can see here, and you can buy the module for your smile design. In digital smile designing, as conventional one, we should consider the principles. For example, we should check the incisal plane to be parallel with interpupillary line, tooth axis to be parallel together and a little conversion to the midline. We can check the gingival zenith, papilla, the incisal embrasure that is related to the sex and age of our patient. We can check tooth proportions, and totally we should provide harmony in our designing. Here we can see a two-dimensional smile design. In two-dimensional smile design, we have a photo of the patient smile and intraoral frontal view of the patient. And in this photo, you can see with a simple Photoshop or a Keynote software, we model the tooth shape and check the measures exactly, and we check about the curve of the smile. And after designing, we can transfer it to the cast and conventional waxing according to this modeling. And here you can see the result that is really pleasant in comparison to the pre-op photo. Also, the smile designing can be done to three-dimensional. You can see here the patient photo, extraoral facial photo at rest and during a smile here, and also a close-up view of lower third of the face at rest and a smile view. And in the software, with having the scan of the upper and lower jaw and occlusion, we can design the smile by adding some parts to them, and we can check this addition in occlusal view and lateral view, and we can check simultaneously this addition in the photo of full face and close-up at rest and at the smile. Here is a short movie to check about the procedure of smile designing. First of all, we should mark 2 points in the cast and in the photo of patient to superimpose and best fit this cast with the face of the patient. And after that, we should mark the tooth show, and you can see here. We mark the pupil to draw the reference line, horizontal and vertical reference line, and the small curve according to the lower lip. And after that, we can choose the type of the teeth according to a library. There is lots of tooth model, maybe thousands in the library of the software, and we choose the best one for our patient according to sex and age. And then we can correct and modify them individually. And it has a really great advantage that we can check every changes in 3 dimensions, means frontal, occlusal, and lateral side. And we can check for the measurement. And after that, when it's acceptable for the face, we can go further on the cast and adapt the designing to the gingiva of the patient, to check about the occlusion, to make harmony with the other side, and some modification and correction in embrasures, as you can see here. And after that, when it is okay, we can export it to the file and print the cast as a reference for aesthetic treatment. After wax-up, we have mock-up. Mock-up is a diagnostic procedure, and mock-up is like a smile simulation happening directly over patient teeth, and it's something like a test smile. Actually, it changed temporarily the shape and color of teeth in order to check the changes. And it is used in the first step of a smile design procedure. You can see here the pre-op view of patient, the wax-up, and the mock-up. Mock-up has some purposes. First, it's a useful communication tool for the patient and dentist, and it simulates the final outcome. The result is temporary and can be changed according to the patient desire, and it can be repeated as many times to select the best possible solution. It helps create trust between patient and the dentist, and dentists can evaluate the patient desires and change the treatment plan according to it. And usually in a smile designing, like the photo you can see here, the changes are really significant. And our patients need time to understand and get relation with them. And in this time, we can get some photography to analyze the mock-up and to check the proportion of these. And also we can discuss about the result with patient and his or her family. Sometimes when the mock-up has the right thickness, we can give it to our patient to go home and ask from people who is important for her or share or him to share about their comments and points. But mock-up have some limitations. Actually, it's not possible in all the cases. For example, cases like crowding. In these cases, we need to modify or have a preparation on these overlapped parts of teeth prior to mock-up. And it's not a thing without any irreversible thing. And we cannot do mock-up in these cases, and we can evaluate the results after preparation in provisional stages. And we can consult with our patient what to do. For example, in these cases, you can see crowding here, here, and also here, that mock-up cannot be feasible. In some cases, the changes may not satisfy your needs, or the patient is not happy with the mock-up, and you consider to change the treatment plan completely. For example, choose the orthodontic treatment instead of cosmetic treatment, and it's really an advantageous point. For example, in this case, we can see a successful mock-up and treatment. Here is the pro-op view of patient, and then mock-up, and it's the final result. As you can see, the contour and anatomy of teeth in mock-up is really similar to final one, but the type of material and color is a little different. In this slide, we can see the conventional method of mock-up. We have a wax soft cast. We prepare a silicone index out of it. There is putty and also light body to have an exact and accurate silicone index or silicone key. As you can see here, we remove the excess in the vestibules. And then we prepare some escape way in interdental papilla for escaping the excess of the material. Then we inject the temporary material inside the silicone index. Usually this type of material is acrylic material, and then we place it in the patient mouth and wait for setting it up, and after that we remove. And you can see here the mock-up on the patient teeth. We can have a transparent or clear silicone index, as you can saw the last slide, but it's advantageous to use composite temporary material and use light cure out of it, because the composite material have better color and is more stronger than the acrylic material. In a digital method, we can have cast printing, means after VSD, we can print the cast and make a silicone index out of it. Or we can have a vacuum shell, as you have in bleaching tray, over this printed cast and use them for mock-up. In this case, you can see digital smile designing and printed cast and vacuum shell on it. We can inject composite material inside the vacuum shell and place in the patient mouth. After removing the excess, you can see the result. It's the pre-op view of patient and it's the view after the mock-up. Also, we can have a silicone index print, means after DSD, digital smile designing, we can plan and design an index out of it, and we print just this index. You can see here the printed index, and the color is black. It's useful for acrylic temporary material, and it's the result of mock-up. Also, we can print the silicone index out of clear material, and if it's transparent, we can use composite temporary material, and you can see the result that is more beautiful, better in color, and more stronger. For mock-up, we can use milling also. Means after digital smile designing, we can get a output file for this laminates and mill them out of the PMMA blanks. And it's advantageous that we can model 3 or more different model and milling them and try in the mouth of the patient and ask for him or his or her comments. Also, we can have mock-up printed, means for this case, you can see these two central is not favorable in looking, and we plan for 3 different type of central teeth. As you can see, the model of embouchure, contacts, and the curve of the incisor edge, and we can print this third and check in the mouth of the patient at a session, and patient choose between them which one is best for him or her. Okay, this digital smile designing is really nice, but has some limitations because the diagnosis and treatment planning depends on photography and video documentation. Each inaccuracy in them may distort the reference image and may result in inaccurate diagnosis and planning. For complete 3D digital workflow, 3D software with updates, intraoral scanners, 3D printers, CAD/CAM, milling machine are required, and they are really expensive and everybody cannot afford it. Training and handling for certain software are necessary, which it increase the time and cost of treatment. Moreover, in this chart, you can see a comparison between digital and conventional wax-off. In accuracy, time, and symmetry, digital is superior than conventional. But in making harmony, predictability, and satisfaction of patient, they are same and can be acceptable for our works. And at the end, I want to finish my lecture with a nice case. You can see the pre-op photo and the digital smile designing and printed cast, the mock-up and preparation of these from the mock-up and the final preparation. And you can see the scan. We can superimpose the mock-up and digital smile designing on the scan of preparation and have the final restoration. You can see the final restoration that are really nice and so natural, so pleasant with relation to lips and in macroaesthetic view. Thank you so much for your attention. You can be in contact with me with this email address and Instagram page. Thank you for your accompany with me in this session.
Thank you so much, Dr. Atri. It was very informative, very comprehensive. Thank you for joining us and having a lecture for us. We will ask if there is any question for you. So if there is no question, we can go for the break.
Thank you.
All right, we're gonna have a half an hour break now. So after that break, which will start at 11:30, we're gonna have 4 more lectures up to 2 p.m. So
Iran time, Tehran.
Iran time, Tehran time. So please write down if you have any question. We can answer during the break time or after break. Thank you, everybody. Thanks for wonderful lectures, and see you in half an hour. Done?
Thank you.